Well, what we've learned recently, I suppose, by way of introduction, we have three pathways we treat pulmonary arterial hypertension. We have PDE5 inhibitors, a bit like Viagra or sildenafil or tadalafil. We use these drugs. Endothelin receptor antagonists as well that we use, and then prostacyclin drugs, hitting the prostacyclin pathway. And what we've learned is it's not just about treating one pathway at a time and working the way through it, but it's actually get the patient early. We usually start double up front oral combination therapy now with a PDE5 inhibitor and an endothelin receptor antagonist. But what this data is showing us is, well, if a patient's not doing well early on, you should consider triple therapy for those patients. So we're getting more aggressive, I suppose, in the way that we approach things. We still only have three pathways, and we've had three pathways now nearly 20 years, but we're getting better at using those three pathways and understanding how to attack those three pathways.
Yeah, no, I think that's exactly right. I think that, again, getting back to the Griffin trial, when it showed in the original study that about 80% of the patients in that study were already on therapy, some other therapy. And so that was an add-on therapy. In fact, about a third of patients were on two background drugs. So in those patients, the selexipag, the Travi, was the third drug. And yet, even when we analyzed that, whether they were on background therapy or not, they still had the benefit for the primary endpoint. And so I think, again, that raises the point that, in the case of pulmonary hypertension, we believe, more drugs are better, and that every time we do a study with an additional drug, in this case of Travi, we still see a treatment effect. I think that's a very important message, and as Sean outlined, in this particular subgroup where we looked at treating earlier, that seemed to be associated, with a good effect.